After you, I have Doris. Dr. Zahreddin and Dr. Hassoun. Just admitting a few more people. So I'm gonna make a start by first introducing our speaker today, Dr. Almudena, who works in Cadiz in Spain and has been doing and has done a huge amount of research in lung ultrasound. She has already spoken to us and given us an absolutely amazing talk on chronic lung disease and bronchopulmonary dysplasia, something that we will be focusing on after the end of this month, including the diaphragm. I want to take this opportunity to thank her again for sparing her valuable time and speaking to us today. What we are going to do today is we're going to have 4 peer reviews, and after the peer reviews are over, we'll then have Dr. Almudena's talk. Again, we're very, keen for us to not limit questions. So if you have any doubts on any area in lung ultrasound, today is your opportunity to ask one of the biggest experts in the world in lung ultrasound. So I am going to let the lovely Margarita to start, please. Margarita, go for it.
Thank you. Okay, it was a non-reassurance CTG that went to a C-section. Amniotic fluid as meconium. It was a 40-week baby with 3,510 grams. You need the positive pressure ventilation with oxygen, and he stayed with the RDS in need of oxygen. It didn't have infectious risk and went to the NICU and it was put in CPAP with 40% of oxygen. Then that need to arise, and he was intubated with aggressive ventilation because he has a meconium aspiration syndrome. So I didn't have courage to do the scan while he was unstable, because each time we move him, he rises oxygen and took a lot of time to go down. So he was extubated to here to FiO2 of 35%, and in the 14th day of life, he was in nasal cannula with 0.1, 0.2 liters per minute when I did the last. So these are the R1 and R2. Okay, it's a thin pleura. It's a bit broken here. Well, we have A line, B lines with A lines underneath, and maybe a deep consolidation here. I'm not sure. And in R2, we can see also a thin pleura, regular, and A lines. There's some B lines, not very much. I think this is quite nice. So I can see it's a B profile here and here. Can I call it an A, or it's too much?
I think I agree. I think that looks like an A profile to me. Can you just let us know which probe you're using? You're using a linear probe.
It's a Vivid GA. I don't like the touch screen, not at all. With a linear with 12 hertz. Okay.
Very nice. So yep. So just if you were to follow our guideline and report from the pleura down, you've definitely got pleura all the way through.
Yes.
What do you think? Regular, continuous in R1?
I think it's a bit irregular, some broken here. Maybe it's not a thin, pretty thin, but can I tell that it's well, it's a bit thick. Yeah, it should be, it's thick, a bit thick. I shouldn't say that it's linear, right?
Sure. Fair point. I think you're absolutely right. It looks a little bit on the coarse side. Definitely, once you've seen sliding, what about sliding?
Yeah, I think it's sliding.
Okay, excellent. And once we've interrogated the pleura, just further down, I think I'd completely agree. You definitely have a dominance of B lines, definitely a few B lines that coalesce possibly into a compact B line, especially on the right side of your screen.
Yeah.
And the question, again, from our perspective, is whether you do have a deeper consolidation on the right bottom side. Very good depth, up to 4 centimeters. Nice visualization. The beauty of the GE machine, the Vivid that you use, is you do not have to adjust the actual kind of focus to be at the pleural line, in that it auto adjusts, which is something that's really remarkable about it, which is why for our colleagues, I can see a marker there at 2, but actually the new GE and Vivid doesn't actually need the marker to be anywhere. It actually auto adjusts to try and pixelate to the best quality. And that's why you can see, the lungs in their entirety right down to the bottom. So very nice. Any other comments? Anybody else think or have any questions from the group?
Yeah, I have a doubt. Here it's like to be a track sign. Sometimes it's...
So should we just play it again?
Okay.
So yeah, definitely on the right side. So if you just go to the right, just above the level of the diaphragm, there, I definitely think, and maybe in the middle as well. So,
here,
but
right.
yeah,
But
the presence. Yeah, it has B lines, and the B lines move. So theoretically, from your perspective, it's very unlikely that you've got a pneumothorax there.
Yes.
You do have a little bit of what I'd say is lung pulse. Do you think there's a mild effusion there? Small effusion?
Maybe here, yes.
Yep. I just think you've got a tiny effusion as well. So very nice. I would agree with that. What do my other colleagues think? Does anybody else want to comment?
Look, I don't know if you are finding every time this truck sign, because sometimes when we are doing some ultrasound and it says A profile, we notice this truck sign, but MOD doesn't show any pneumothorax. I don't know if it is possible.
No, it is, and this is the important thing. It's a mirror artifact. So a mirror artifact, the presence of a truck sign in isolation with pleura that's sliding in B lines, it is very much visible in babies who don't have a pneumothorax. So and that's the importance, that really those 4 signs for a pneumothorax are very important. The absence of pleural sliding, the fact that you've got an A profile without B lines, a barcode sign, and you must, where possible, demonstrate the lung point. So truck sign, yes, if it's present with all those signs, is an additional feature, but you can actually see truck sign, in an A profile rather than an A- profile. So I wouldn't get too fixated on the fact that if you have a truck sign, you're always going to have a pneumothorax. Look at all those signs, and those 4 signs that I've just spoken about are very crucial. Please carry on.
Okay, this is R3 and R4. I think that's nothing special. It's we see a thin pleura with sliding, with some B lines with A lines underneath in both sides. I think here the image, especially in the R4, it's more dark, maybe a bit of gain here. Sometimes I raise the gain, but then everything stays very white. And I think I can see better with a bit less gain, and I can see A lines, because because if the gain is too high, it's all white and everything looks alike. Okay, but I think here there's nothing special.
Yep, I would agree.
Okay, so can I move?
Yep.
Excuse me, may I?
Here I try to do.
Sorry, there's somebody wanting to ask a question.
Sorry.
Yeah, this is Almudena.
Go for it, Almudena. Yeah.
Hello, thank you, and hello, everybody. I would like to also thank Alok for inviting me to be here. It's a pleasure, and always I'm very thankful always for this great special presentation that he does always, which I don't deserve. I just wanted to make two comments. This is really quite images, the one that you've showing us, Margarita. And the first one that you've already passed, you mentioned that you have doubts about a consolidation there. There's no, maybe there's a consolidation, but you cannot really see it, because if you see it, it's unless you have a consolidation itself at the level of the pleural line, everything that you can see underneath is just artifacts. Whichever you see, it cannot be a consolidation, never. I don't know if you understand the concept. Unless that you have fluid or consolidation, atelectasis, whatever you have underneath the pleural line are just artifacts. You don't really have that image itself in the lung. I don't know if you understand.
I can't assume it because it doesn't start in pleural. I just can assume things that start in pleural, right?
Yes. If it doesn't, then it can be it's just an artifact that you are seeing there. Okay. It cannot be a consolidation, never.
Okay.
Okay.
Thank you.
And in the next one.
Next.
The next slide. Yeah. You were talking about the gain. Yes. You can modify the gain only in the lower parts of the image.
Okay.
That's
sectoral gain, right?
Yes, and that's what should be recommended, because sometimes it's very usual to see what you're seeing here in the image. When you lose brightness in the lowest part, then you have to modify just the gain in that part of the image.
Okay.
I don't know. Yeah, don't change the global gain, but only the gain that's in the lower part of the image. These are a specific bottoms or that usually have the machines that you move them from one side to side, and then you can just adjust the gain there, that location. Okay.
Okay, thank you.
So on the GE that you have the vivid, it will be lateral gain compensation. And what you'll find is when you click on the screen, it will give you a series of buttons which allow you to move from up to down, so that you can actually alter the screen from up to down.
Okay.
Go for it. Yeah.
Now I try to do flaps that we talk in Sunday. And here, can I assume there is a consolidation? No. No.
No, again, you're seeing a thin pleural line. You cannot have a consolidation if you're watching a pleural line with B lines. It's the same concept that we were saying before. You are seeing different density there, but probably it's an artifact. Okay. Because if you see the pleural line, it means that you have two spaces or two fields with different acoustic impedance. So you have impedance of the water, which is the subcutaneous tissue or whatever you have there, and then you have air, and this is why you have the pleural line drawn there, because you have a difference between two tissues with different acoustic impedance. This is why all echoes are reflected, and then the machine draws the pleural line. Okay.
Okay.
So that means that you have air there, with a bit of water or with some inflammation, but you have mostly air. Okay. So you cannot have a consolidation.
Okay. Okay, so it's the same here. It's not. It's just the B lines with the pleuras, thin pleura, and here it's R6. I think this here, it was too low. I suppose it might be guts, right? It's not.
Yes, probably.
Okay. Oh, and then it's the left lung, and it's the same. It's a key. I think it's normal, right? Like I can say this normal lung, or yes, and here also. It's the question, the key. Okay, sectorial gain will improve, right? I hear it's not
Yeah, probably.
4, it's 5, and with a sectorial gain, it would be better the image.
Yeah.
And okay, I think it's a meconial syndrome in recuperation. I don't know if you say like that. You have to give him time.
Yeah, this is kind of like the type of images that you've seen after the acute phase of the aspiration syndrome, in which now pleural line is almost normal, but you still see a few areas with a B profile or mixed A and B profile, which is an interstitial pattern.
Okay.
Yeah, that's the usual evolution.
So, and here I try to raise the PLAPS sign, see, and it was okay. So, and here I try, it's L5, L6. These I changed I put some sharp in but I don't think the image get much better because it's blurred.
And you increase the depth too.
Yes. It's not necessary, probably. What do you think?
No.
Okay. Okay, this was my first case. And the second, it's very simple things. This is a newborn. It was a mother with a chronic kidney disease that had a kidney transplant rejection and developed a pulmonary edema. It was done 1 dose of beta and urgent fetal extraction. It was a late preterm that born well, but started to need in oxygen. It went to CPAP first in 40%, and then he drops quite fast, quite quickly to 25. And I did the scan at 12 hours of life. Here it was to help me a bit with the scores. Oh, sorry. Okay, it's skin, muscles, ribs, bad sign, and there's pleural sliding, thin, regular pleural line, A lines, and the counting of the lines. I think it's almost normal here. And so it was a profile with a broad score of 0. And here, maybe here we see most than 2B lines and some coalescence. So I would give a 0.5 or 1 broad score. That's okay?
Yep.
Here is the lateral. I have all 3. Here it's there's, well, maybe more gain, give me more B lines here. The pleural thin and regular is sliding. We have seen A lines beneath the B lines. Okay, maybe a bit of gain more in a B profile, a broad score of 1, right?
Yes. Yes, perfect.
Here, okay, pleural sliding. I think pleural is a bit coarse, and although it's regular, we have some compact B lines, but we have spiral angled zones here and here. Here it's more obvious because the B lines are more compact here and here. So it's a IS interstitial syndrome of B profile. When I see is spare lung zones, probably it's more favorable to TTBN, and it's not to use broad score because it's not, broad score is for RDS. But if I have to classify it, I would give it a 2, right? Am I doing a right? This is a correct thought or not?
Yes, if the question is about the number, yes, it would be number 2. But the question about the scores, we use them, although we don't have a suspicion of an RDS. in publications about TTN, it's also used, the same score, although it was first published with the aim to try to detect the infants with high risk of needed surfactant. It was also used in TTN. We use the same score for BPD prediction, and so on.
So this is R3 and R4. It's okay. It's the, I think, sorry. It's also pleural sliding, coarse pleura, regular, compactly lined, spare lung. There is, in the beginning, I think it was the same zone because the baby is small and the linear probe is big. Sometimes when I do R2, the upper part and then the lower part, there is in the image it's a zone of that it's the same lung. Okay. Well, here I can call it a white lung, right?
Yes.
So my conclusion, it was a brief profile with an interstitial syndrome with spared zones. Well, it was a late preterm without corticoids, just one dose and with no labor. So probably it's a TTNB.
Yeah, I think so. You should also add that the pleural line was thin. You didn't saw consolidations. There are spare zones which are against on RDS. We could also saw the double lung point, which some colleagues have suggested in the chat. So I think that we all agree it would be a TTN.
Okay. The double lung point was here. You log in the first one, this part here?
No.
No.
These are quite good images.
Here, this is
maybe between this one and the previous one. I don't know if you had something in between.
Yes, I had a L4 here, but I didn't put because it was too much images.
The thing is that I'm not used to the order where you show the images, but maybe this would be lateral or
yes, it's lateral.
Yeah, but maybe between this lateral and the posterior fields, maybe you would see more clear the double lung point.
Okay.
Okay, because in the posterior ones that you show in the next slide, then maybe you almost have a complete wide lung there.
Okay. Okay. So it's what I have to show. Thank you a lot.
That's beautiful. Fantastic. Really nice images and food for thought. I mean, two really good diagnoses that you've kind of made. Our next colleague who's going to present is Dr. Zaradeen.
Yes. Hi, good evening. Yeah.
And then Dr. Hassoun after that. So Dr. Zaradeen, go for it. You can share.
Thank you. Can I go ahead?
Please, by all means, all yours.
Thank you. So this is a late preterm born at 36 weeks of gestation and 6 days, just under really term, with a birth weight of 2.7 kilos. He had mild respiratory distress to start with. He did not require much of a stabilization at birth. He was started on high flow nasal cannula, 6 liters per minute. However, he became unwell with respiratory distress, severe signs of respiratory distress and increasing oxygen requirement up to 45 and sometimes 50%. But he was at some point even apneic, and his oxygen saturation really was hardly in the high 80s, low 90s. So he was, when he developed profound apneic episodes. He was, as a matter of urgency, he was intubated and ventilated, given surfactant, 1 dose. I've managed to do his first lung ultrasound scan just after intubation and receiving the first dose of surfactant. And then the second scan was done a week later when he was extubated and on high flow. So I'm just going to go through the first set of lung scans. This is R1. The first lung ultrasound scan was done obviously when he was unwell, so I was unable to do the posterior views. This is R1, and I can see the pleural line looks coarse and regular, with subpleural consolidations and what I think is static bronchograms. There is which he's now ventilated, so with each breath, I think I can see some B profile with coalesced kind of B profile, but with inhalation, I can see the static bronchograms with the consolidation. It was a bit tricky at that point. He was very unwell. To be honest, my main aim of the scan at that stage was to exclude the pneumothorax.
So how old is the baby at this age, Dr. Saladin?
About 5 hours.
5 hours. Any history of meconium?
No, not at all. Not at all.
No history of meconium. Okay.
It was straightforward, late preterm.
No rupture of membranes. Mother's not GBS positive.
Not at all. No risk factors of infections. It's just the fact that mum went into labor. She did have a previous history of. She's a known case of thrombophilia. So she had one pregnancy loss. During this pregnancy, she was on aspirin and low molecular weight heparin, which was stopped recently. Before the heparin was stopped only 2 days prior to delivery. Not sure if.
What do we think about the subpleural area in R1? I'm just curious.
I think it's. To start off with, I thought this might be a consolidation because of pneumonic changes, and I was thinking of congenital pneumonia as a possibility. Honestly, I wasn't expecting this at the time of doing the scan. I was, as I said earlier, the main aim of my scan is that sudden deterioration and I was really keen to find a pneumothorax.
Yeah. My question is whether, especially when the baby kind of inhales and you see aeration, you actually get a visible shred sign. I'm just wondering, Almudena, what do you think?
I was answering the chat. I don't think we can see a shred sign here because you don't really have a static consolidation in which you would see the shred sign underneath the consolidation. You're seeing a big consolidation, not a subpleural one, which is kind of recruiting when the ventilator insufflates the gas, and it de-recruits when it sails. So you should have a static consolidation to see this red sign underneath the consolidation, which we are not seeing clearly now.
We can definitely see some dynamic air bronchograms there just at the top when the baby inhales, do we think?
No, I think all of them are static. Okay. Although maybe, I think the movement that you see is the recruitment at the recruitment, but not it's the gas inside moving, I think.
Sure.
But just to be sure, which locations are those images from? Is it the right lung or right and left?
No, this is R1 and R2. R1 on the left side of the screen, and then going down, that is R2.
So right anterior upper and right anterior lower R2 would be right
Okay.
at, yeah.
Okay, thank you.
Sorry, yeah. Then I moved on to the, still on the right side, laterally. So perhaps the sliding of the pleura is clearer here, but still you can see the consolidation just beneath the pleural line, as well as the air bronchograms. With the dominant B profile, I can't see any A lines, except on R1. If we move to R1, going inferiorly, there is perhaps one A line or some A lines that I can see to the very right of R4 images. But otherwise, again, it is the mainly B profile.
I would agree. I think, subpleural consolidations, static air bronchogram in R3 right in the middle, kind of a compact B-line appearance, and, features very suggestive of an RDS over here in R3 and R4. Dr. Almudena, any comments? Anything?
No, unless this is more or less the pattern shown in the other lung. It doesn't seem to be a congenital pneumonia, because it doesn't have really spare areas. It's more or less the same. It's a de-recruited lung. Maybe this baby should have benefited from
higher pressure.
Yeah.
Go for it. Please carry on. Yeah.
So I'm just going to move to the left lung to see the pattern being a widespread. And the L1 images, again, showing not a clearly defined pleura, and I think probably that is disturbed by the consolidation underneath it, and a B profile with the heart beating also interfering with the images. If I exclude the heart beating, it is pretty much a replication of R1, I would say. And then on L2, again, the pleura is probably better defined, still a bit broken at certain points with the subpleural consolidation, and then the B profile, the air bronchogram, so similar pattern. Might be, there might be some A lines, perhaps, some of them, but here it is predominantly the air bronchograms. And then,
yes, as you are explaining quite good, the lung is more or less the same. All images show similar signs, in which you are seeing a de-recruited lung in a late preterm infant, which is maybe should have benefited from higher pressures or surfactant, as you said, this is performed before surfactant administration. And there was someone in the chat asking whether if there was the double lung point in the previous slide in R4.
I'll go back to R4. Is he talking about here?
Maybe that point. Really, the concept of double long point is what we see in the TTN, instead of seeing different patterns in the same image. Usually, we see better aeration in the non-dependent areas, which will be anterior or higher areas, and worse aeration, a sharp increase in lung ultrasound score, or increase of B lines in most depending areas, in posterior or lateral areas. But this is not the concept of double lung point. This is just an area that seems to be a bit more aerated, in which we don't see consolidation, we see again the pleural line. We see just one or maybe two A lines. So it seems like in the lower part of the lung, this concrete area is a bit more aerated, but that's not the concept of the double lung point.
So what Almudena is saying is, it's a really important point. So if we just go back to that image, it's really, so especially if you go to the left bottom of your image, what you're seeing is well aerated lung, and the markers of the lung being better aerated as compared to when you go to the extreme left of the image, where you've got kind of a B profile with subpleural consolidations, is the visibility of the pleural line. Now, if you can see pleural line, then you definitely have some element of aeration up to the pleura. So really, it's not a double lung point. And as Almudena has kind of alluded to, we should theoretically use the concept of a double lung point when we're talking about TTN. I mean, this looks like a pretty well-established RDS at the moment. It'll be interesting to see what your other images show. Yeah, go for it. Yeah.
Thank you. So I'll just show you the left lateral views. Again, they are showing same findings of the pleural sliding with the subpleural consolidation, or even deeper consolidation with a predominantly B profile on the picture, both on the upper and lower left lateral views. So clinically, my reflection on these scans is that I was actually, in a way, I was pleased, because I could say confidently that there wasn't a pneumothorax, explaining the pretty sudden deterioration in this baby. So I was to some extent confident, and I was pleased with myself excluding that. Then obviously your comments, Alok and Almudena, spot on. I think we gave this surfactant, but still we went up on the ventilator settings. It looks like the lung did not respond just for the surfactant. They needed a bit of more pressure, so the pressure went up. Maximum was 26 peak inspirator pressure. Once I think we reached that opening point, things have improved overnight, and baby was actually oxygen requirement went down from 60% down to by the following morning it was about 25%, and the blood gases were much better. So started weaning, and the baby was extubated, and I didn't get a chance to repeat the scan until the 7th day, and here are the scans on day 7. With these, this time I was able to do even the posterior images as well. So this is the right upper and right lower. Again, very nice looking pleural line with sliding comet tails, predominantly A profile with A lines, nicely seen. The air bronchogram has disappeared, I guess, and both right upper and right lower anterior are showing the same picture. I think on R2, probably the liver is coming into the image every now and then.
Just 2 comments. Yeah, you are doing quite well, and you're interpreting the improvement of the image quite well. But maybe just to comment on, you don't need that depth in your image. You have 5 centimeters. Maybe you could have reduced this a little bit, and also changing the time gain compensation, the gain in the lower part of the image. Maybe you could have changed it not to see it that dark there, like the previous colleague that was also explaining her case, Margarita. Okay.
Thank you.
Which machine are you using, sir?
Sonosite.
Sonosite. Okay. Yeah. So again, it's worth having a look at whether you have time gain compensation or lateral gain compensation, because they'll change the images slightly differently. One of them will be vertical, And like if you have the GE, it tends to have what I'd say is lateral gain compensation. So it actually moves and changes the image in a slightly different way. And in the GE, often you have to sort of reduce the frequency to get a little bit of better imaging from the depth. But in the sono side, if you have time gain compensation, then actually you can actually do partial segments in every area, which is beautiful. It's a very nice machine.
So I will just look for the button of time gain compensation. I've made a note of it, so I'll
yeah.
Actually, I will contact the rep as well.
Lovely, well done.
Thank you. Can I move on to the next?
Go for it, please, please.
So these are the R3, and so this is the lateral views. Again, pleural sliding, no bronchograms. The consolidation is not visible, and it's mainly an A profile. That's both on the right upper left, right left lateral. I'm just going to the left side. Sorry, this is the posterior. So these are the posterior views, which we did not have, obviously, because of the condition of the baby. But now it's and these were done first because the baby was actually prone. So I did the both posterior right and left first, and then the baby was turned over, and I did the anterior. So he's been on prone for some time when these images were taken. And again, there's a very clear pleural sliding with A profile, A lines all the way through on both right upper and right lower posteriorly. I'm just going to move to the...
Very nice images.
Thank you. And this is the left side. Again, comet tails with very, I think it to me looks a very good opportunity to train my eye on pleural sliding. Comet tails and A profile. Perhaps I have lost some of the contact here at this point, or maybe it's the heart causing this.
Probably the heart, yes.
Yes. And then that's the left anterior lower, L2. Similar findings. I'm just going to go to the lateral views on the left side. Again, very clear pleural sliding with normal pleural image, A profile. Perhaps every now and then there might be some remaining, not sure if that's correct, but remaining B profile, especially on the L3. But that's probably just a sign of improvement, I guess.
Yes.
The L4, there is mainly, it's an A profile image with pleural sliding and comet tails as well. And then finally the posterior images for the left side. And they are showing pretty much similar picture to the findings on the lateral. Baby is comfortable.
Quite a normal scan.
Yeah.
Is it?
Yeah.
Very nice images, well performed.
Thank you. And this is finally just the X-ray. This is the first chest X-ray just before intubation. And that was this baby actually, after intubated and given surfactant and increased ventilatory pressure, there was a significant improvement radiologically on the X-ray, although it was not reflected immediately on the ultrasound. So timeline between these two X-rays is about 3 hours. On the same day, on the day of birth.
Yeah, that's one of the limitations that we have using lung ultrasound, in which you see clinical improvement after surfactant, but you don't see an improvement in an ultrasonographic signs until at least 6 hours after the treatment, because you have to think that you are introducing a liquid inside the lungs. So more or less the image that you see are quite similar until that surfactant's absorbed into the lung and it disappears. You don't begin to see an improvement or not. But you can see a clinical benefit before you see an improvement in the images, really. I think the point that you said at the beginning of your presentation, it's quite important, in which you said, I was proud because I was able to rule out a pneumothorax in this infant. So with what you've learned now, you're able to distinguish quite well the reason for clinical deterioration of your infant, and I think that's very important. You see the usefulness of using lung ultrasound in clinical scenarios, in real clinical settings.
Absolutely. I mean, I'm very, very. I was and I am very, very happy with this, and thanks to you all. I think it's a magnificent achievement. Thank you so much. That's all due to your hard work.
So just one last question, Dr. Zahreddin. Clinically, I mean, in terms of infection, culture is negative, CRP is normal?
Absolutely, yes. The baby had a normal CRP all the way through. The blood cultures were negative. I started him on antibiotics.
No, absolutely. I think in our part of the world, we wouldn't risk it. But yeah, I mean, again, a very nice, kind of a ultrasound to kind of demonstrate subpleural consolidations and, what is kind of quite a severe presentation of RDS with a good response to surfactant. So, my compliments.
Thank you so much. Thanks a lot.
The next person who is going to share with us is Dr. Hassoun. Please go ahead, Dr. Hassoun. I'm really grateful. Thank you.
Good evening, all. Just share the screen. I'm audible and visible?
That's correct.
Okay, thank you. So this is just a case of 35 weeks, C-section delivery and meconium, multigravida mother and GBS negative, gut respiratory distress, admitted to SCAPU, high flow nasal cannula, FiO 2.6, and then intubated and giving Cerventa. This was in the night. So I did ultrasound the second day, but after 12 hours of Cerventa, just to see what is the finding, what could I find on lung ultrasound with meconium aspiration syndrome. The chest X-ray was typical for meconium aspiration syndrome with heterogeneous patchy infiltrate bilaterally. So I will start by right lung, right upper, R1. Just 1 second, sorry for that. So for this one, sorry, but I cannot keep it in loop, just 1 second.
It's okay, don't worry.
I think I could not. So sorry, I will keep it like this, so I couldn't look.
It's okay. They're very nicely visible. Yeah.
Well, this is just for me. This is a good pleural sliding, thin pleura, but just there is a lot of B line with B profile on right on up, right anterior up, upper zone, and there is here shred sign for me, and I don't know if I'm doing this very well, but there is some shred sign on this view on right R1 was a consolidation. I don't know if this is right or not. So on the R2 right down, also the same pleura is sliding. There is B profile and sorry, This is the second one. So, and there is also suspicion here of shred sign and atelectasis consolidation. I couldn't put, I forget to put Doppler on this image. So I don't know what is your input, Dr. Aloko, Dr. Almudena.
Yeah, I think you can see consolidations in red sign almost in all image that you've presented.
On both view, on right upper and right lower.
The one that you have in the right light, yeah, there you can see. If you
and
can stop it, yes, in both.
Okay.
But
okay.
the ones in the right are in the left one are bigger, and those in the
Here. Okay.
Yes,
okay.
You can see this is not really a red sign because this is quite sharp, the limits between the consolidation and the rest of the lung, but it will be probably atelectasis, not a pneumonia. That's what, but this is more or less, yes, this is more or less the concept of consolidation, different from the other images that we've seen from the other colleagues.
Okay.
You lose the pleural, you lose the pleural line, you see a consolidated area, and underneath then you see hyperglycemic line that's kind of separating the consolidation from the rest of the lung. Okay.
Okay. So next one, this is lateral view right lung, R3, R4. Here's the R3. Also, the pleura is sliding here, and B profile mainly. Some A I could see in the middle, and also the same some subpleural consolidation. For the R4, here the pleura is sliding, also some B line, and I could see a profile, so AB profile, but no atelectasis or subpleural consolidation. That's right. Yes.
Yes. Were there analytical signs of infection in this baby?
No, CRP, the first CRP, two CRP was first one was negative. The second one little bit rise, just till 10, not more. And the baby after Cerventa, he was giving Cerventa, so we moved from FiO 2.6 to 0.21 after 12 hours.
Okay.
So this is the left side. This still here the posterior part of the right lung. Okay, also B profile, and some subpleural consolidation and with A line. So AB profile was, I don't think this is subpleural also consolidation. Yes, there is subpleural consolidation.
No, only just a tiny little one in the third intercostal space, but just less than 0.5 millimeters. Yes, that's okay. The only one that I can see there.
Okay, fine. So here, this is L1, lung, left lung, left upper. Here also there is some B line with A, so AB profile.
Yes.
Sorry, maybe I got confused here a little bit. Sorry, this is the L2. This is L1, L2. Sorry, I mistaken. But also the same issue, we comment on it. And here's the last one, this two. Also the AB profile with some subpleural consolidation one. And here AB profile. But just I was so confused from the first image. If I this is a shred sign or atelectasis, I couldn't find it just from at the beginning. This is my worry here. What was this? Is a shred sign or this one, or what is this image with hypoechogenicity here?
It's not irregular enough, yeah, for me to be shred sign, but let's see what Almudena thinks. Yeah, it's
no, yeah, it seems it seems like an atelectasis. You don't see a bronchogram inside. You don't really see the shred sign. You see an intersection between the consolidation and the rest of the lung, but this is quite kind of sharp, not really like a shred, and probably will be an atelectasis. The main issue is why this patient does have this atelectasis in this location, because the rest of the lung seems quite good aerated, and he has improved clinically also. So but that was, I was asking about signs of infection. Maybe it could also be congenital malformation of the lung, maybe, or maybe it could be this an aspiration, not a meconian aspiration, but maybe blood aspiration or amniotic aspiration after birth. I don't know. I should have wanted to see previous images when the baby was more unstable to try and to decide, and also to see the evolution in the next days.
Unfortunately, when was I give Cervanta, it was in the night, so we did it just a second day to see what is our finding.
Yeah, that's very usual.
So, and this, you think that if we could put a Doppler here, it will help?
Well, not really. Not really, because you're not seeing anything inside. Just watching the lung collapse there. That's an atelectasis. Probably you won't see anything at all. However, in neonates, the point of having a static or a static bronchogram, moving bronchogram, different organization in Doppler exams is not that validated as in adult or children references. So it's not that useful, really.
Okay, thank you. Thank you. This is just one case. I will.
Well done.
Well done. I will give the opportunity to the other. Thank you. Thank you very much.
Thank you, Dr. Hassoun. Our last presenter today is Dr. Doris. Doris, we have about 5 more minutes. So
okay.
Thank you so much.
Thank you. Thank you for the opportunity to present. I'll just take this away. Okay, so the case I'm presenting, it's a case of a 23 plus 6 weeker who is corrected to 29 weeks today, well, yesterday actually, was at day 37 of life, was 705 grams at birth. He was born by spontaneous, slideshow. He was born by spontaneous vaginal delivery, unexpected, but mom had 2 doses of steroids, was intubated, had Curacef at birth. And I mean, the initial 2 to 3 weeks of life, he was stable on the ventilator, treated for the first 48 hours with antibiotics for suspected sepsis. And the first time they attempted to extubate him, because he was still in a significant amount of oxygen, they started postnatal steroids. But just before the end of the course, came on well and was noted to have blood cultures showed late onset GBS, so had a 10-day course of IV antibiotics, and he was reintubated again at that point. So 10 days ago, he was another course of steroids were started in a bid to try to extubate him, and halfway through he became tachycardic unwell. We screened him again, and he grew GBS again, and we started antibiotics. But because he was not as unwell as he was previously, we just extubated him, and he was on CPAP or BiPAP, and his oxygen requirement started rising, and we just could not account for that. So I'm just showing his x-rays, the transition. This was the first x-ray on the right is at birth. After he was born, he was intubated, lines were put in. And at 1 month of age, this is after he was reintubated again, after the first course of postnatal steroids. Okay, so the ultrasound. So I did the ultrasound scans yesterday because of increasing oxygen requirement, frequent desaturations, and I just wanted to see what was going on. And this is the first scan, R1. So as you can see, the pleural looks continuous, but it does look irregular. There is pleural sliding seen. And it looks irregular and below the pleural, whether these are subpleural consolidations. All mainly B lines. It looks compact to me. So this is certainly a B profile. That's my talk. And so because I thought the pleural looked quite irregular, I zoomed in to try to interrogate that area of consolidation. And So looking at this area, you can still appreciate the irregularity of the pleural sliding. And then I was looking at this area and I was wondering is this dynamic air bronchograms? Is this shred sign? Sorry?
More subpleural consolidations, I would suspect. And my only comments, I mean, like when you look at R1 in particular, it's kind of a whiteout as opposed to compact B lines. And what's your gestation? 23 weeks weight?
Baby was 23 weeks at birth. Now is corrected to 29 weeks. He was
weight?
He was 700 grams at birth. Currently now he's 1.2 kilograms.
Sure. Okay, that's really helpful. Yep. It looks more like a whiteout to me as opposed to, yep.
Yes.
I agree.
Yep.
Almudena, anything else you'd like to add? Go for it.
The thing is that to understand these images, we should
need to see the previous ones.
Yes.
Yep.
Maybe this is the images. Maybe this is the images that this patient has since birth, or at least since 2 or 3 weeks before. What this images is telling you that probably you have ruled out complications because you are really intubating the baby because you think that maybe there's something that may seem worse. You see that there doesn't seem to have a pneumonia. Nosocomial pneumonia can be ruled out with these images, at least in these areas. Probably what you can understand from these images is something that we're going to review in the talk that we will be having today, is that maybe this infant's not ready to be extubated. Okay, because you're still seeing a completely white lung, at least in these areas that you're watching now.
Yeah,
you can rule out pneumothorax with this thing. You can, with these images, you can rule out pneumonia, and you can rule out atelectasis due to position. Probably this infant will have these images since weeks ago, and probably this is a patient evolving to a BPD, and in which you can see that this lung's not ready yet to be extubated. Is it because PDA? Is it because an evolving BPD? Is it? But
no PDA. We excluded PDA. So okay. I did not, unfortunately, I didn't do an ultrasound much earlier on to see what there was a transition, but these are the images. I did it because of the rising oxygen requirement and in a bit, and I did it before I did an X-ray, because I said, let me see what the lungs look like. And I mean, I do agree, it seems like whiteout, dense B lines, which I found really puzzling at this age, 37 days old, corrected to 29 weeks. Yeah. Okay.
That's an evolving BPD. It's just, yeah.
And so I really couldn't get an R2 view, and from the X-rays will show why, because his abdomen was so gaseously distended and his lungs were being pushed and squashed. So this was the R3 view. I took it in the axillary area. And sorry, where is it? Oh, sorry, back. Okay. And as you can see, is the same. You can appreciate pleural sliding, the irregularity of the pleura. I thought it looked thick, and whether these were signs of subpleural consolidations, and mainly B profile. With this, in this view, I mean, in the last R1, the B lines were so, it seems like whiteout, but this one, I can't see any A lines anyway, but it doesn't seem as compact or whiteout as the R1 view, but as you can appreciate, it's just mainly B lines. I couldn't see any A lines. So I actually tried to zoom in to look closely at this area also. I was suspecting whether these are also subpleural consolidations, just below the pleura.
But this is normal due to the position. Probably the baby was in supine position.
Well,
this is not a clinically significant consolidation, just very small ones. That's what we call subpleural consolidation, although as Nadia Youssef told you a few weeks before, that Dr. Daniel Lanchestein doesn't want us to say that to use that term, but those are small atelectasis at the level of the pleural line. That will be the concept that some people use to say subpleural consolidation. When you find a bigger one, that's when you call it extensed consolidation.
Okay.
My only other comment, do you really need a depth of 5? Because what is happening is you're losing out on the deeper part of your image. So especially in a baby this small, you might actually not need that much depth. You're actually hitting 5.5.
Okay.
Yeah.
Okay. And this R5 view, I took the view at the level of the posterior axillary line because I couldn't turn him to do the posterior view. But it's all mimics the same, as you can see, pleural sliding, regular pleural, B profile. Now the left side, L1, can still appreciate the dense in B lines, pleural sliding, but the pleural looked more irregular. And at this point, I thought that this was Schreck sign because the pleural seems broken.
Yes.
Continuous at this point.
Yes.
Okay.
I agree.
All right. So I zoomed in again to look closely at that side, and you can see what it looks like. It certainly made me increase my suspicion of Schreck sign. As dense as it was. So I tried to put the color Doppler on at that point, but I don't know why I couldn't get it better than this, so I just abandoned it.
In case that you want to use Doppler, then it will be better at what Alok told you, that decrease the depth of the image.
Okay, all right, I'll try that next time. So L2 is still all B profile, pleural looking thick and irregular, and then this point at L2, I think this is Schreck sign.
Yes.
The pleural is broken at this point.
Yes.
Okay. And L5 taken at the level of the posterior axillary line on that side. The same, just mainly B profile, pleural looking irregular, especially around this area. It looks thicker than the other side. And sorry, same thing. That was the same thing. So I looked at, after the x-rays, after the long ultrasounds, and I went to look at the rest of the x-rays. He had an x-ray 3 days before. This was while he was extubated, 3 days before. So you can see how his lung fields look. There's lots of gas in his abdomen. And then this was the So this was the x-ray that was done after the long ultrasound. You can see how gaseously distended his abdomen was. His lungs were virtually looking collapsed, which explained virtually, like you said, whiteout appearance on his lungs. So we started diuretics and we just reintubated him. He was still on the course of antibiotics for late onset GBS, so that continued. I actually, my reflection, I thought it was quite interesting. I did the long ultrasounds first before I requested the x-ray, and I was actually quite surprised to see how white out his lungs were at this age. And it was one of the questions I was going to bring, that is this a sign of evolving chronic lung disease? And yeah, then I did the x-ray and it confirmed that yes, his lungs were looking white out. Either they were collapsed or as these were all mainly signs of evolving chronic lung disease. So yeah, thank you.
It could have been an acute RDS secondary to the sepsis also, but you wouldn't see the lung so homogeneous. You would see some areas with consolidation, small ones, bigger ones, other areas better aerated. Would be like meconium aspiration syndrome, the images that you would see. But in that case, when you see such homogeneous lung all white out, that probably is an evolving BPD, what you are seeing. Maybe you should rule out pulmonary hypertension also, if the baby is with many fluctuations in oxygenation.
Yeah. Okay. Yeah, the oxygen requirements were close to 70 to 80% at the time of this X-ray. So, okay.
definitely needs recruitment. Yep.
Intubated.
Yep. Lovely. I think this sets up a really good kind of a session, because Almudena is actually going to talk to us about that. And without further ado, I'm going to hand over to Dr. Almudena. Thank you so much for joining us.
Okay, should I begin now?
Go for it. All yours.
Yeah.
Yes,
okay.
Beautiful, visible and audibles. Thank you so much.
Well, we're going to divide the talk in two parts, in which the first one will be about prediction of admission to NICU for respiratory distress in term or late preterm infants. And then we're going to talk about the optimization of respiratory support, mainly in preterm infants. So please go ahead and ask whatever you need. You may interrupt me whenever you want. The thing is, why this is not working? Okay. The first thing will be talk about which is the normal aeration after birth in preterm infants using lung ultrasound. You all know now in this part of the course that you have to see this more or less this image. This is the concept or normal aeration that we have in all ages, not just in newborns. We have this subcutaneous tissue here, the ribs, intercostal muscles, then the pleural line, these A lines, no B lines. But this is not the normal in the first hours of life, as you all know that you are beginning to perform lung ultrasound exams in your patients. In the delivery room, there's a group in Australia that began to evaluate the lungs using lung ultrasound at the level of the axilla, just in the very seconds after birth in term newborns. And this is some videos that they provided in the publication, in which you can see that when the baby is born, the lung is completely collapsed, as you can see here. And after 2, 3, 4 seconds, then you can see how it progresses to a completely wide out lung. Or in this one here, you can see the progression from a consolidated lung here, and then it moves to a consolidation with air bronchogram that progresses with the respirations of the baby to a wide out lung. So this is the normal progression of aeration using lung ultrasound in asymptomatic term infants without respiratory distress. And this is what we have to know to decide whether if a baby that has respiratory distress is doing quite good transitioning after birth or not. And this same group that we are talking about performed another study afterwards, in which they observed how lung ultrasounds were changing after birth in term infants without respiratory distress and without congenital malformations. And they evaluated the infants at the first 10 minutes of life, in the second 10 minutes, then in 1 hour, 2 hours, 4 hours, and 24 hours of life. And this is what they saw. They divided the images that they got in the axilla of these patients in infants with this normal aeration, which they call it like a pattern number 3, thin pleural line with A lines, no B lines at all. Pattern number 2, in which you can see an increase of number of B lines with thin pleural line. Pattern 1, in which you can see a wide out lung, completely full with less than B lines. And they divided the infants in the profile that they showed in both lungs. Bilateral type 3 will be the normal aeration that we are used to see in asymptomatic patients. Then we have type 2 in one lung and 3 in another, 2 bilateral 2, and so on. So in the first 10 minutes, you can say that this type 3, bilateral type 3, was only seen in 20% of the infants, term infants asymptomatic without respiratory distress, and more or less the same in the next 20 minutes and in the next hour. So if we are watching if we are evaluating a term infant with respiratory distress and we see this pattern here or here, maybe that infant is still transitioning. Maybe the lungs still full of water, and we are not able to see whether if the infant is will need in admission to NICU for the distress that he or she has. However, after 2 hours or mostly after 4 hours, almost all infants progress to a bilateral type 3. You see, 4-6 hours is a bit later than the time that we usually spend evaluating an infant with distress, and until 24 hours is not when practically all infants had this bilateral type 3 pattern. And they also evaluated this, dividing the infants in the type of delivery that they had. They divided them in those born by vaginal delivery, a cesarean section without labor, or elective cesarean section. And you can see that there are differences between the groups in the first 10 minutes, 20 minutes, then an hour. And there's always a decrease of aeration, a decrease of removal lung water, extravascular lung water, in those babies born with without labor by an elective cesarean section, and it continues to improve after 2 hours, and then practically it was equal the pattern, the profile, the bilateral 3 profile in the 3 groups after 4 hours of age. So you can see how the extravascular lung water is removed slowlier in infants born without labor by an elective cesarean section. But you can see that there's progression of aeration. The normal aeration of a term baby is different from the aeration of other ages. But this is not only in the first hours of life, in the first day. What happens afterwards? In this study, colleagues from an Italian center in Rome, they analyzed the progression of lung ultrasound aeration in healthy term babies in the first 7 months and the 6 months of age. And they analyzed the number of fields where they have 3 or more long B lines in every field. And you can see that at 10 days of life, almost 1/3 of the infants had this image of more than 3 long B lines and interstitial pattern, although they were completely asymptomatic at birth and didn't have respiratory distress. And it remained 1 month, and at 3 months, only just about 10% of the infants had this image. But at 6 months of age, none of them did have more than 3 B lines in interior fields, both right anterior and left anterior. So this is important because, as you have seen now, the progression of normal aeration in infants, in term infants, newborns, is not the same as in other ages. So this will be an schema of how normal aeration of the lung is seen in term infants, in which we can see both lungs with thin pleural line, A pattern, or maybe a B pattern with separated B lines, mostly in posterior areas, more dependent areas. But to understand and to interpret this, you can see this, as we have been explaining before, the aeration of the most dependent areas is like more deficient or more slow than the rest of the areas that we are evaluating. So in most of the studies that we are going to review now, the posterior areas of the lung are not evaluated in the first hours of life to try to detect which infant would be the highest risk of being admitted in the NICU. So now we're going to review the evidence that we have published up to date about prediction of admission to NICU due to respiratory distress using lung ultrasound. And this is the first paper that we got in 2012, in which an Italian group from Naples analyzed the patterns of aeration according to these 3 categories that we've been explaining before, and the needed of admission afterwards. I remember that we have this normal aerated lung, which is the pattern 3 profile. Then we have an interstitial pattern, or increase of the number of B lines will be number 2, and the colistem B lines will be number 1. And they analyze the infants according to the need of oxygen requirement or respiratory support and the need of admission to NICU. And you can see how all patients, 95 patients with this type 3 pattern, didn't require admission to NICU. And all infants with this pattern after 1-2 hours of birth required admission to NICU, and most of them required respiratory support. However, most of the infants, just 4 out of 46, required admission when they have this bilateral type 2 profile. So taking these results into account, the existence of a bilateral type 1 pattern in the lung of a term infant in the first 1-2 hours of life had this sensibility, specificity, and positive and negative predictive values for being admitted to NICU due to respiratory distress. So this is important because we can use these images to decide if an infant has to be transferred to an hospital, to a different hospital. If I work in level 1 or level 2 NICU, maybe I need to transfer this baby to another place to where he would have different respiratory support, or maybe I should pay more attention and I should monitor that infant more carefully in the next few hours, because that patient probably would need more attention from our part. This study is performed just taking into account both upper anterior, lower anterior, and lateral fields, which would be R1, 2, and 3, I think, from your schema. And they didn't take into account posterior fields, as we were explaining before. So another Italian group, a few years later, performed this study in which they used similar methodology, but they only analyze infants born by a cesarean section, whether they have a TTN or RDS, whether they were 10 infants or late preterm infants. But they wanted to know, as we all know, that those babies born after a cesarean section without labor do have a decrease or slower removal of extravascular water. Maybe these results could be reproducible in this population, and they did. In this study, all infants that required admission to NICU had both type 1 in both lungs, as you can see here. Well, almost all infants. There was one with one type 1 and one type 2 lung, and the one with a type 2 bilateral. But most infants that they didn't require admission to NICU had this type 3 in both lungs. So you can see that there's the lungs didn't show the same progression as the ones before, because infants that didn't require admission to NICU both had this type 2 profile. But also you have to pay the attention that when you see this pattern here, whether it's the baby is born by a cesarean section or vaginal delivery or not, then you have to think that this baby has a high risk of being admitted to NICU, okay? However, this study published a few years ago by a Chinese group, they performed it a bit differently, and they divided the pattern shown in the lungs of the infants according to this classification that they created of low-risk patterns or high-risk patterns, in which they had the A pattern or B patterns with more separation or reduced separation of B lines, compared to a group of high-risk patterns in which they included colistem B lines or whiteout lung, or the existence of consolidations. And they analyzed the risk of needing any type of respiratory support, which would be the black image, the black line, or the need of invasive mechanical ventilation, which would be the blue line. You can see that both high-risk patterns did have a high area under the curve for being admitted or requiring invasive mechanical ventilation. However, the low-risk patterns do have also a high area under the curve for not being admitted. And this is area under the curves, and this is the risk, the odds ratio of predicting admission in the babies with an A-line pattern or B pattern, in which there's a decrease of the risk of being admitted compared to infants with choleston B lines or consolidations that have double the risk of being admitted to NICU. They also analyzed not just anterior and lateral fields, but also posterior fields, and they counted the number of fields in which the infant had this high risk or low risk patterns, and they got these results in which if you see 2 or more fields with high risk patterns, they increase the risk of being admitted to NICU or the risk of requiring invasive mechanical ventilation. And now, I don't know if you have more questions or comments or something that you want to clarify about this. Is it all clear? Wanted to show you a few cases of how we do it. This is a term infant born by vaginal delivery that require resuscitation at birth and that develop respiratory distress in the delivery room, and then we perform lung ultrasound first 30 minutes of life. And you can see here this images. This will be one lung, anterior, upper anterior, lower anterior of the left lung, and lateral one, in which you see subcutaneous tissue, the ribs, the pleural line, which is sliding. Then you see both A lines and just a few B lines. Okay, this will be a B pattern, interstitial syndrome in all fields evaluated. This will be a low risk pattern. This infant, although she had respiratory distress, we already knew that wouldn't need admission to NICU. That could be with her mother, which was the case. Finally, just in a few hours, you're only required to be a short period of observation in the maternity ward, and then she could be transferred to the maternity ward again. Another case will be a late preterm infant born by a cesarean section due to the transverse presentation that didn't require resuscitation at birth, but also developed respiratory distress. And this will be lung ultrasound performed at 1 hour. This is the left lung. Sorry for not using your terminology, but more or less will be anterior field, lateral field, and posterior field of the left lung. You're seeing these images with this thin pleural line, a bit fragmented. It's small pleural effusion here, but really quite small. A few B lines here and also in this field, but they are more together, almost completely coalesced B lines in posterior fields. But in the right lung, we can see more or less the same images in the anterior and lateral field, but you can see a huge consolidation with air bronchogram without pleural line and with SRED sign in this area. This you can think that this baby would have high risk of predicting admission, but really she didn't. She was completely asymptomatic in 2 hours of life. 2 hours, I think I have, no. The lung was completely normal, aerated just 2 hours afterwards. And this case is useful for you to understand that in the first hours of life, evaluating posterior fields is not that useful because it doesn't give you important clinical information for you to decide on the risk of a patient, okay? You have to pay attention more in these images here in anterior and lateral fields, which will make you decide what's the right attitude for this patient. The next case was also a term newborn with a normal pregnancy that required also resuscitation at birth and developed respiratory distress afterwards. And this lung ultrasound performed at birth, in which you can see upper anterior. Oh, this is moving quite slow, I think, I'm afraid. Sorry for this. Upper anterior, lower anterior, and lateral field. Well, you'd see there's also ultrasound of good prognosis with only a few B lines here, a little bit more in this area, and more crowded here in the more dependent areas, but this is not a high risk pattern. And this is the lung ultrasound performed 2 hours after 2 hours of life. And you can see how all fields are very aerated without consolidations, without B lines. Almost, I think I can only see one B line here in this image. So the infant was transferred successfully at 6 hours of life to the maternity ward again. This is another case, just 2 more for you to see how we do it. This is a term baby also with a IUGR, and she was born due to elective cesarean section, and she had a prenatal diagnosis of a hair lip. She also developed respiratory distress, but now in this case, in the first lung ultrasound that we performed in the first 30 minutes of life, she was on mild respiratory distress. We may be able to see how we see, you can see the mouse here. We don't see lung sliding at all. We don't see B lines neither. We see only A lines in this area here. If we use the M mode, here you can see the transition from the beach sign to the stratosphere sign. This is moving quite slow, I'm afraid. And however, I don't have the image of the lung point, sorry, but you can see how in more dependent areas, you see lung sliding again, and also B lines. So this will be a pneumothorax, a small pneumothorax. And this is the lung ultrasound performed at the same moment, but in the other lung, in which you can see a normal pattern with a low risk of being admitted to NICU. And this was a very small bubble of pneumothorax with a double lung point, with the lung point, sorry, at the level of the mid-clavicular line, that the infant didn't require drain of the pneumothorax, and she was able to begin on enteral feedings, and she just developed mild respiratory distress for a few hours, and she was discharged home at 1 week of life due to the heart lip, not because of the respiratory distress. And this is the case that I wanted to show you. As you have seen the previous one, this is completely different. This is also the clinical history is more or less the same. It's a term infant born by a vaginal delivery, a quick delivery, in which we are called because the infant has respiratory distress at 3 hours of life. Probably he will be on distress before that time. And this is the first ultrasound that we perform at 3 hours of life, in which this is one lung and this is the other, upper anterior and lower anterior. And you can see this thick pleural line, fragmented pleural line with lung sliding, but with lots of B lines. Also this area here with the small consolidation, with pleural effusion, a bigger consolidation here, and lots of small ones next to them. There's another one here. So this lung is the type of lung in which you should really pay attention to. This infant was directly transferred to NICU and began on nasal CPAP, and the baby was able to remove non-invasive ventilation after 36 hours of life. So this is the clinical picture of something that you have to pay attention to. This infant, if you work in a level 1 NICU, should be transferred to another NICU to receive enough mean airway pressure to recruit this lung. However, the other infants will be low-risk infants that really needed much than a few hours for transition and after birth for the respiratory distress to be alleviated. So that's it. And this is about prediction, respiratory distress, and admission to NICU. And to show you how you can do it, you have enough knowledge now to to able to differentiate from one pattern to another, and also may help us to rule out some diagnosis like the mild pneumothorax or other images that we've seen here. I don't know if you want to comment or something or questions. Let me see the chat. There was someone here asking about the median time of the ultrasounds. I thought maybe it was in the papers about prediction of admission. It was about 1 hour, 1 hour and a half after birth. That was the median time. Okay. So if you don't have questions, then we can move on to the optimization of respiratory support using lung ultrasound.
May
Yes.
I ask a quick question?
Yes, yes, please go ahead.
Thank you. Thank you very much for the first part of the presentation, and the studies that you went through for prediction. There is a great amount of thought, and I like the classification, and that's very interesting. However, I can see that up till now, the main trigger for spotting these babies is the clinical presentation. Perhaps I'm not sure if these studies are mainly for research purposes, because they are very nicely enforced the thought of the evolving of the lungs. And when we actually go even with a stronger belief, when we go and counsel parents about TTN and the improvement in the lung fluid and cesarean section and all the rest of it. But again, the clinical picture is the trigger. If the baby has respiratory distress signs, then we go in and maybe do a lung ultrasound scan, while universal screening for these babies to predict who goes to what, that is probably still, at least in my setting, is still not very practical to be implemented.
But why? Because you're not able to perform lung ultrasound, or?
No, I think
I don't understand.
My question is, again, sorry about the confusion. Based on the prediction model, I still don't think that I will be in a position to justify going and scanning all babies to predict who is going to stay with the mother and who is likely to be admitted to an ICU and who is borderline.
No, I mean, maybe I misunderstood you. The decision, the final decision to admit an infant to the NICU is just clinical. I mean, it's a requirement of oxygen, increase of work of breathing, or whatever. But using lung ultrasound early at 1 hour of age, or even 30 minutes of life, you may kind of divide the infants in the risk of predicting, in the risk of needing admission afterwards. And if you see that pattern, the low risk pattern, then you can understand that this infant, you won't need to see him again afterwards. I don't know, it does more or less.
Yes, thank you. My point was how practically this could be implemented, the prediction model. That was, and you've answered that. Thank you so much.
Well, when a baby develops respiratory distress after birth, we are called, and then we go and evaluate the infant, and according to whatever protocol you have in your unit, you have to decide whether if the infant remains in the delivery room or in your unit when you observe your patient until the distress disappears or increases, and then it's transferred to the NICU. So another sign that you can use, in addition to the clinical signs, the work of breathing, oxygen requirement, or whatever, is the lung ultrasound. So there's something more that may help you to decide whether if the patient can just stay there for a while and afterwards be transferred again to maternity ward, or maybe you can observe that infant more intensively, or even transfer directly to the NICU. That will be the difference.
Thanks.
Okay. well, so move on now. Let's move on, and we will be in the second part of the talk. We will be talking about NIV failure after admission to NICU. This is more or less the progression of an infant in our unit, in which the baby begins with respiratory distress. It's transferred to the NICU. We begin NIV in whatever type you have. Then the infant requires intubation if it fails. And after the intubation, the period that the baby is intubated, maybe we need to extubate him, and maybe we can predict extubation failure. Afterwards, we would like to know when the infant's ready to be weaned from the non-invasive ventilation, and we can also use it to optimize the respiratory support that we are giving to him. Change in position, increasing of respiratory pressures or whatever. And just a few slides at the end to talk about PDA and lung ultrasound, as Alok was interested in the last talk that I had. So to begin with, now we have our infant admitted to NICU after we've been seeing before, and we want to know whether if this infant will require to be intubated or remain on non-invasive ventilation, irrespective of the disease that this baby has. You have to understand that we are not talking about RDS, TTN, pneumonia, or whatever. We're talking about functional lung ultrasound. Okay? What patterns make us believe that probably that infant would need to be intubated? Okay. So this group of authors that created the concept of pattern 1, 2, and 3, this late. These are all the studies performed more than 10 years ago. They didn't use lung ultrasounds properly because they were first described a bit later. And they evaluated the risk of being admitted, the risk of being intubated once the infant were on non-invasive ventilation. So more or less the methods are similar. They observe the progression of the infants according to lung ultrasound performed after 2 hours on nasal CPAP. And as you can see here, all infants that had this bilateral type 1 require intubation afterwards. And infants that had this type 2 or type 3, bilateral type 3, didn't require intubation at all. And taking this into account and comparing the diagnostic accuracy of this type 3 ultrasonographic type 3 bilateral with grade 2, with a RDS in grade 2 by X-ray, which they refer to an homogeneous pattern with an interstitial infiltrate with air bronchogram. You can see now that combining the two techniques, the diagnostic accuracy of lung ultrasound was quite better. This other paper was published a few years before. This is also an old one, but they also divide the infants according to diseases with low risk of prediction of low risk of needing mechanical ventilation, or high risk diseases, which will be RDS, meconium aspiration syndrome, pneumothorax, pneumonia, okay? And low risk will be normal aeration patterns or infants with a TTN. Here you can see a double lung point, which is more or less the concept that we were talking before, or sharp decrease of aeration in the same image, okay? And they saw that the infants with this low risk patterns almost didn't require intubation at all. Only one infant with a TTN and one infant with a metabolic acidosis or hypothermia. And the infants with the high risk diseases really require, almost half of them require intubation, mostly those infants with a diagnosis of RDS. And infants with a high risk pattern also require longer period of non-invasive ventilation, invasive mechanical ventilation, high risk of requiring surfactant therapy, and so on. Okay, so now you have more or less the idea that when you see this pattern in an ultrasound, all irrespective of you get to the final diagnosis, this baby has high risk of requiring respiratory support, high risk of being intubated also, okay? And now we're moving to detection of the risk of extubation failure. We all know that invasive mechanical ventilation is frequently used in preterm infants in our units. And this is the population where the risk of having or developing extubation failure is more common, even more in term infants and compared to children or adult settings. And we don't have any test available to predict extubation failure with enough diagnostic accuracy. So, and we also know that the baby has worse outcome if we have different extubation failure, different attempts with failure of the attempt. And if we decide to remain on invasive mechanical ventilation, then we increase the risk of developing BPD and being discharged home on oxygen. So maybe lung ultrasound can help us to deal with this, in which we can try to more or less decide the risk of developing extubation failure after the initial phase of RDS, or after that, after 1 week of life in infants with evolving BPD. Or we can also use diaphragm ultrasound or combination of diaphragm, heart, and lung ultrasound that Dr. Mohammed talked you about this a few weeks ago also. So first of all, we have to think in the first case, we have to divide the according to the moment of life we are talking about. In preterm infants, the first days of life are mainly related to the existence of an RDS. And this has been quite well studied by Dr. Mohammed in this paper published last year, in which they analyzed 45 infants with a gestation age less than 28 weeks, in which they analyzed lung ultrasound score of the infants in 3 locations, which will be your R1, R2, and R3 in both lungs. And they calculated its score, which is not the same as the BRAD score. They use a score of 0 with the normal aerated lung, a score 1 with more than 3 well-spaced B lines, score 2, core less than B lines. And then they divided score 3 into a small subpleural consolidation and extensive consolidation, which will be number 4. And they perform lung ultrasound 1 hour before the extubation in this median, the median days of life when they performed the extubation attempt was 4 or 5 days. And they got here the results in which you can see that those that remain extubated at 3 days of life really had slower lung ultrasound scores before the extubation attempt, and those that didn't remain extubated had higher numbers. Also, the same results were obtained at 7 days of life. And they analyzed both lung ultrasound score and diaphragmatic measurements in the previous ultrasound, the previous to the extubation attempt. And they got that only lung ultrasound score was related to the risk of being reintubated afterwards, both at 3 days and at 7 days. And they use a threshold cutoff value of 15 points to decide in which infant has the highest risk of developing extubation failure. And with this threshold, the sensitivity was 95%, which is quite good, and specificity of 85%. This other paper also performed in preterm infants, but not that preterm. They were late preterm infants. They were more than 200 infants that were divided into 2 groups according to the final outcome of success or failure of the extubation attempt. And they combined, or they analyzed the diagnostic accuracy of lung ultrasound, which is picked in this green line, compared to a clinical model that included respiratory severity score and birth weight and length of the infant. And you can see that both models have similar diagnostic accuracy, both in the initial sample and the sample that they use for validation. And this last paper, which is smaller but maybe easier to understand, divided the infants according to the pattern observed in the lung using lung ultrasound into a normal pattern, which will be this nice image of thin pleural line, few B lines, or interstitial pattern or B pattern with separated B lines, compared to the normal or high risk patterns that had this wide out image of coalescent B lines or beard consolidations. You can see that most infants with the normal patterns had a successful extubation at 3 days after the attempt, and infants with the abnormal pattern had a 50% risk of being reintubated after the attempt. So again, when you see this before an extubation attempt, you have to think that maybe that infant could have a risk of requiring reintubation if you do that in that moment. Maybe you could wait a bit more, or maybe you can decide on other therapies or whatever to try to decrease the extubation failure in this infant. This is an example, a preterm infant born at 27 weeks with this birth weight, that he was born in another center, different from ours, and he received invasive mechanical ventilation at birth. He received selective intubation in the right main bronchus and received selective surfactant administration. He was transferred to a NICU, and he was stable after 3 days. We recollocated endotracheal tube, and we decided to extubate him in a 3rd day of life with this FiO2. But we performed lung ultrasound before, and this is the left lung, the anterior area, lateral and posterior area. And you can see now this alveolar interstitial pattern here in the upper part of the lung. And in the lateral and posterior, you are watching a lot of atelectasis and consolidations, maybe due to the fact that this infant received selective surfactant administration in the right lung. This is the right lung, in which you see very aeration, but also with a lot of water, still a lot of in extravascular lung water. So maybe this pattern should have made us wait and try not to extubate this infant, which we didn't do because we were kind of beginning in that moment. And we extubated him, and the attempt failed just 10 hours afterwards. So this is more or less what you can do with your exams and some other information that you can have apart from just knowing if the baby has an RDS, TTN, pneumothorax, or whatever. Okay. But what happens after the first week of life? If you have an extremely preterm infant, after the first week of life, RDS is over, but most of these infants still need to be intubated due to whatever, inflammation, evolving BPD, or low respiratory drive, or whatever. And in those infants, can we use the same approach as in infants more mature or infants in the first days of life? Well, we don't know it yet because we have no studies published, but we believe that we have to combine both the value of lung ultrasound score and the existence of consolidations and previous to the extubation attempt. And this is because of this. In this paper, we analyze lung ultrasound progression in extremely preterm infants. And as you can see, most of them are still intubated in blue in the first weeks of life. And when we are able to extubate them, most of them are extubated after 1 month. Then we see that in that moment, the babies still have high lung ultrasound scores, but they can be able to be extubated successfully. So maybe we have to pay attention to other signs different from the value of lung ultrasound score itself. And this is a pilot study that we performed with some NICUs, some Spanish NICUs, in which we analyzed the pre-extubation exam. in infants born before 30 weeks after the first week of life. And we compare the respiratory severity score in infants that were successfully extubated and those that didn't, without difference. But lung ultrasound scores were a bit higher in the groups that did have extubation failure, but without really clinical significant differences. But what we also analyzed was the number of consolidations that both groups had. You can see that those with extubation failure had higher number of consolidations. And if you divide the infants with extubation failure according to the moment when they failed the extubation, those that fail after 7 days, which are those that are supposedly not failing because respiratory condition, because sepsis or surgery or whatever, well, didn't really have any consolidation at all. And if we combine all this and try to analyze the risk of developing extubation failure, if we create a model, a regression model that only uses gestational age, birth weight, and respiratory severity score, we have an area under the curve of 0.6 or 0.7 to detect extubation failure. But if we add the lung ultrasound score and the number of consolidations in the lung ultrasound performed before the attempt, then we can increase the area under the curve significantly to 0.8. So maybe in the future, we can say that we have more evidence, not now, but maybe in a few years we will, that using lung ultrasound before an extubation attempt decreases the risk of extubation failure in extremely preterm infants. This is another case. This is a 24-weeker in which we are aiming to extubate her after 2 weeks of life. And you can see in this 4 images, both upper posterior and lower posterior of both lungs, in which you may see huge consolidation in all areas evaluated, probably due to the prolonged supine position. And you can see what happens when we change the infant's position to the prone position. You can see how lung consolidations have completely disappeared. You see a normal aerated lung here and a white-out lung in this area. So this infant was extubated after this changing of position, and the infant had a successful extubation. We don't know if it would have been the case before the changes, but you can see how you can really evaluate the lung, how it is doing and how it is aerated before trying to decide whether to extubate a baby or not. We also analyze ultrasound performed after the extubation attempt, and you can see how there's no difference in the lung ultrasound scores, neither in the number of consolidations. So maybe this is not as useful. We are now combining results from different hospitals in Europe and in the US, and maybe in the future we could give you more information about the use of lung ultrasound to reduce the extubation failure in this population. Another case, this is also a 24-weeker without significant comorbidities, but we were unable to extubate her. This is at 14 days of life with FiO2 21%. This is her first extubation attempt. And this is her lung ultrasound before the attempt, in which you see a thick pleural line, which with small consolidations here, which this is not really a bad prognosis. This is quite normal in the 24-weeker at 2 weeks of life. This is something that we can deal with, and this is something that we can try to extubate this patient. However, the patient was moved to non-invasive NAVA, and although the images are not of high quality because of the distress the baby had, you can see how the lung has changed to an increase of consolidations in all areas evaluated, completely de-recruited lung with a big consolidation here in this area. And this baby finally failed the extubation attempt and required intubation again. And also we have to also pay attention to the diaphragm ultrasound or maybe the heart, but this is something that has already been explained in previous talks, so I won't continue talking about. So before continuing, does anybody want to make a comment or a question or something? Okay, so if we move on, we've placed our infant on non-invasive ventilation. The patient failed. The patient was intubated, and after being successfully intubated, we want to know if the patient is ready to be weaned from non-invasive ventilation. I'm talking about preterm infants, okay? So this is the only study published up to date on this issue, in which this group of Canada analyzed the lung ultrasound score before the attempt of removing nasal CPAP. And you can see the area under the curve, which is quite high for using this technique before removal nasal CPAP. And before the first trial of weaning of non-invasive ventilation, you can see the difference between those groups with successful weaning and failed weaning, both before and after the trial. And they use this threshold of 8 points to decide which infant is ready to be weaned, with this sensitivity, specificity, positive, negative predictive values in the 24 hours before the trial of CPAP withdrawal, okay? So this will be an example. This is the normal image that we see in extremely preterm infants on non-invasive ventilation. You see that there are not high-risk patterns in this patient. They're just this thick pleural line with lung sliding. We don't see any consolidation. We don't see atelectasis. This is just B lines in the whole lung. So this is the normal issue. So this is the normal, but this is not something that we, although the baby could be on FiO2 21%, but if the infant still has these images in their lungs, they're not ready to be weaned from non-invasive ventilation. We have to wait until we see this change that we can see here. We can see there are more spaced V lines. Pleural line is thinner. We don't see consolidations either. So maybe if the infant's still stable with low respiratory settings and lung ultrasound seems like this, then maybe the infant is now ready to be weaned of non-invasive ventilation. Okay. Here I show you a case, all are real cases from our unit, 28-weeker. It's a triplet. She was born to a urgent cesarean section due to a higher IUGR. She requires resuscitation at birth, and she required non-invasive ventilation for 8 days. And she didn't require surfactant at birth. And this is her lung ultrasound at 8 days of life, in which you can see how pleural line is thick but very fragmented. It has lots of small atelectasis at the level of the pleural line. We can see lots of B lines all over the lung, which are not completely coalescent, but are really quite tight all together. And that was the left lung, and this is the right lung, in which we see more or less the same images, okay? After this, the baby is transitioning to nasal CPAP, and she remains stable with this FiO2. And at 28 days of life, she's still stable, so we decide to remove nasal CPAP, but after that, the baby's not doing well. And you perform lung ultrasound, and you see how the lung has changed, okay? Although you still see fragmented pleural line, you still see B lines, you see that the millimetric consolidation that were just located at the level of the pleural line have been increased. You see bigger ones here, but also bigger one in this area. This is the left lung, and this is the right lung, okay? This is a slight differences, but if the infant really is not doing well, still needs oxygen, and you see these signs of de-recruitment, then the infant needs to be placed again on non-invasive ventilation or nasal CPAP. So again, when you are beginning or you are deciding to remove nasal CPAP, if you see this image, this is not the best decision for that patient at that moment.
May I?
Okay.
One question?
Yes, sure. Please.
It's about stopping in non-invasive ventilation. When they are in CPAP, do you stop once? Well, you decide to stop, or you do small, some hours of non-CPAP, and then you put on CPAP, and then you do some hours without CPAP?
We usually remove nasal CPAP, but in case that the infant begins with respiratory distress or requires oxygen, that we place it again. We don't remove it in an intermittent. We don't use the intermittent way of removing nasal CPAP.
Okay, another question. When we remove CPAP and then they get worse, we think they do they under-recruited, and can see seen in the lung ultrasound. Well, it starts to appearing that subpleural consolidations that are corresponding to the collapse of alveolar collapse.
That's the idea. That the idea is that when you use lung ultrasound, you can see the de-recruitment of the lung. Okay, here you can see this is an example of this, in which if you see that the lungs was aerated, the baby needs oxygen again, and you see this appearance of consolidations mostly in all areas evaluated, then you can think that this infant is getting de-recruited and needs again non-invasive ventilation. That would be the idea.
Okay, thank you a lot.
Thank you for your question.
To decide or to, sometimes people in the NICU are not all think the same. If we have to put it or take it off, and it's a way of seeing what is happening in the lung of the preterm.
Yeah, of course, with lung ultrasound, there's a lot of people that really don't believe in it. So don't try to use this as the Bible in your unit. You have to begin little by little. There's not much evidence yet, but it will, because this is something that really works. But you have to more or less understand and more or less try to get like the history of your patient. You cannot evaluate your patient only when it gets deteriorated. You have to, it's the same as you use your stethoscope, you explore your baby every day. So more or less you should have the evolution of the lung ultrasound pattern of the baby from birth until discharge. I'm not saying to use lung ultrasound every day, but at least every 3 days at the beginning, then after the first week, maybe weekly. So you can see the evolution of the lung, and you can see the difference if the baby gets worse or if it gets better. Okay, that's my recommendation. This is another example. This is a live preterm infant born at 34 weeks. Born by a cesarean section, didn't require resuscitation, but high work of breathing. So he was transitioned into nasal IPPV without improvement. So he was intubated and he received surfactant administration. This is the X-ray performed after the extubation, in which the infant was moved to non-invasive ventilation because of work of breathing. And in the X-ray, we can see telectasis in the right lung. So when we see the baby for the first time, as it happened also to you, it was his 9th day of life. He was still on non-invasive ventilation with mild respiratory distress, and blood gases showed this moderate respiratory acidosis. Or maybe you use different units of the PCO2 for you to understand. And maybe we think that maybe this is due for the atelectasis that's still persistent in the baby. So some of my colleagues suggested to be moved to a lateral position, but then we first perform lung ultrasound. And you can see here that both in the left lung and in the right lung, there's no images at all of consolidation, neither atelectasis. The lungs quite well aerated now. So we can say that the reason for the respiratory acidosis of this baby is not in the lung, okay? So we decided to remove non-invasive ventilation. The baby really had thick mucus plugs in the nose, so we deobstructed it. And in the next few hours, although he persisted on my respiratory distress, he normalized low gases and he was able to be weaned from non-invasive ventilation successfully. And now a few words about also how to optimize ventilatory support, although this is something quite variable because it depends on each patient and the disease they have and the situation where they are. But I wanted to show you just a few cases. This is a late preterm infant with uterine growth retardation, born with 700 grams without respiratory distress at birth, but she required laparotomy after that due to a spontaneous intestinal perforation. She was stable in respiratory settings after the surgery, but 3 days after, when we get to the NICU, she's on a peak inspiratory pressures of 19, FiO2 40%. So maybe we can think that maybe this infant's developing nosocomial pneumonia. So we perform lung ultrasound, and next to the heart, we can see this consolidation here with a bronchogram. Okay, this is the right lung. So we decide to aspirate the mucus plugs and nurse her. We place her on left lateral decubitus. We perform after this a new lung ultrasound in which we see that the consolidation is improved, but still not completely aerated. We perform cultures, blood analysis without signs of infection, also tracheal aspirate without any bacteria. So we decided to increase respiratory settings and finally replace the endotracheal tube, which was not correctly positioned also. And after all these measurements, we were able to recruit the area and we cannot see the consolidation at all. So after this, the baby was transitioned again to low respiratory settings as she was before, and we were able to extubate her successfully. Another example, this is quite often seen in our patients. This is preterm infant born at 29 weeks. He had a perinatal asphyxia and severe RDS. He required 2 doses of surfactant and invasive mechanical ventilation. He was extubated at 5 days of life. And as you have been listening before, we perform routine lung ultrasound at 7 days of life, usually in these patients. The patient now was stable with normal gases, low FiO2, and in the lung ultrasound performed at 7 days of life. This is the lateral area of one lung and posterior area in which you can see a huge consolidation with air bronchogram, static bronchogram. And the patient didn't have fever, not any signs of infection. This is something quite usual. And so we decided not to act really because he was quite stable, but we decided to reevaluate him again, after this on the next day, in which we can see that the blood gases are getting worse. The baby needs the same oxygen, but with lower saturation values. So, and the consolidation is even bigger. So this is something quite usual and has easy solution because we just need to prone the baby a few hours. This is at 10 a.m. and at 6 p.m. We can see how the patient has really improved both normal glasses in that moment, FiO2 21% with normal saturation values. The lung has greatly improved, and then we can in this way, we can optimize respiratory support in this position. There are many publications about recruitment maneuvers in infants ventilated, during anesthesia or whatever, but we don't know if this really has clinical impact in very low birthweight infants on extremely preterm infants. I mean, not in acute exacerbation, which is quite clear that we need it. I mean, in small infants, very small infants like this T1, These T1s are 24 weekers in which we are performing retune lung ultrasound. They didn't have respiratory distress, normal thoracic excursion, low FIO settings. And you can see that both have huge consolidations here with a bronchogram inside. They are related to the endotracheal tube was too deep, so they had this huge consolidations without really clinical significance in that moment. So we don't know whether if we have to really change our action or change the way we manage our infants now that we are able to see this. However, there's no evidence on this issue, of course. However, we have this paper that I wanted to show you, in which these are adults. This is an adult ICU in which they treated adults after RDS with two different groups. They had this intervention group in which both physicians and nurses treated the adult patients using lung ultrasound to decide whether to increase respiratory settings, nurse the patient, change the patient's position, and the control group did quite standard treatment without lung ultrasound. You can see that the time on mechanical ventilation was reduced in the intervention group, also the treatment time in ICU and the total hospitalization time. But also the intervention group had reduced number of aspiration events and reduced number of ventilator and nosocomial ventilator pneumonia, okay? So maybe in a few years' time, we will be using lung ultrasound as well as our stethoscope or other clinical signs that we use to evaluate our infants. And just a few slides about PDA and lung ultrasound, because Alok was interested the other day. And these are the 3 papers published analyzing lung ultrasound scores in the first days of life in infants with persistent PDA, although they have some methodological issues that make them not very understandable. But this one, which was published to try to use lung ultrasound for BPD prediction, they also analyze lung ultrasound score in different moments according to the situation of the ductus, and they divided infants with a closed ductus arteriosus and a PDA. And you can see how there are difference in the values of lung ultrasound score between 2 groups at day 1, at day 3, 4, and at day 7. But afterwards, there's no differences at all. More or less, although the infants still have a PDA, the values of lung ultrasound scores are more or less the same that those that didn't. And this is another paper about lung ultrasound score evolution in extremely preterm infants, in which they analyze the infants according to different complications. Infants with a BPD were those with light gray, with light gray, middle gray, in which you can see how BPD patients have persistently high lung ultrasound scores, and infants with complications different from BPD, for example, PDA that require treatment, late-onset sepsis, pneumothorax, persistent pulmonary hypertension, they have these light gray boxes, that they also have persistently high PDA that begin to decrease at about 1 month of age. And this is the same moment that infants more immature had this decrease of lung ultrasound scores at the same moment. So are we really watching the evolution of PDA or the evolution of very extreme preterm infants? We don't know it yet. We don't know if lung ultrasound score is usual to monitor pulmonary flow in PDA in extremely preterm infants. And we don't know if we can monitor lung ultrasound, we will monitor lung water using lung ultrasound. What I tried to explain to you the other day is this abstract that we will be presenting in the PAS meeting next month, in which we analyze preterm infants before 32 weeks with lung ultrasound and echocardiography. And we did show a significant correlation between PDA variables in echocardiography and variables related to diastolic dysfunction of the heart. However, if we analyze only those born before 38 weeks, then we see that there's no correlation at all between lung ultrasound and these echocardiography measurements. So these extremely preterm infants do have persistently high lung ultrasound scores, irrespective of they have PDA or not. Okay, so. And the only paper published up to date about the use of lung ultrasound in infants with PDA is this one. This is from the group from Patrick McNamara, in which they analyze lung ultrasound score after PDA ligation, percutaneous PDA ligation in 5 extremely preterm infants. And you can see how the values of lung ultrasound score before the ligation of the PDA decreased just 1 hour before, at the same level at the heart out, the cardiac output also decreased, and they remain lower after the procedure until 6 to 12 hours. And this is performed in infants with a percutaneous PDA closure at 1 to 2 months of age, which is more or less when the lung begins to aerate better in this population. So I hope that after this long talk, now you are able to understand that if you see this pattern, this baby will have, if not admitted, will have high risk of being admitted. If he's on non-invasive ventilation, then he has high risk of requiring intubation. And in his the preterm infant is on non-invasive ventilation with this lung ultrasound, he has high risk of failing the non-invasive ventilation withdrawal, okay? Although you have to take into account that this pattern is good for stable, extremely low birth weight infants, okay? This is not a bad prognosis pattern, but this means that that infant would not be able to cope without non-invasive ventilation. And I hope that you have some questions or something you want to comment on.
So folks, please feel free to come in with questions.
I have a quick question.
Yes, please.
In a baby who is on non-invasive ventilation and you are thinking of taking the non-invasive ventilation off, but the ultrasound scan picture is similar to what we have seen in your presentation. But the other parameters are stable, the blood gases, the FiO2 are fine. Is there a point in escalating the non-invasive ventilation, for example, increasing the CPAP pressure in order to speed up the weaning, or just to sit tight and wait and see?
Well, it depends on the baby and the reason for needing non-invasive ventilation. If the infant is on is a persistent ductus arteriosus, that maybe he could be begin on diuretics, or maybe you may think of treating PDA, whatever. But not increasing respiratory settings, I think, because if the baby is stable with low respiratory settings and it's an extremely preterm infant, you only have to wait. The only thing that you can do is just wait, because the lung's not de-recruited. It's the lung that he needs to have at that moment. But the only information that you can have with the evidence that we have now is that that infant probably won't be able to cope without non-invasive ventilation.
Thank you.
Thank you for your question.
Any other questions, folks? Okay, I am going to take this opportunity again to thank Almudena. Thank you so much for an absolutely fantastic talk. And again, a little bit more reason for us to kind of start looking at babies for slightly older. But I think coming back to one of the important points that Almudena has made is it's really important that we kind of have a baseline kind of a view for babies who are extremely preterm. And I think starting next month, there's an opportunity for us to maybe look at a few babies like that to kind of see how they're doing and see if we might be able to kind of get some scans that are serial scans to kind of look at the evolution of lung disease. It would be a really good practice exercise and something that I think I will add to the logbooks after this talk. Thank you so much, Almudena, and thank you everybody. I'm really grateful for everybody's patience and for the peer review. Peer review will carry on. And on Sunday, what we will be talking about is some of the medical legal aspects, especially with regards to lung ultrasound, but we will have peer review before that. Thank you very much.
Thank you, Lak, and thank you all for your attention. Congratulations, because all of you are doing quite a good job. You're on the way.
God bless you. Thank you. Take care, everybody.